Hello, everyone, and welcome to our program. So let's start with a section on managing diabetes with comorbid cardiovascular disease. And we'll start with a case, as we like to do, and the case will be a backdrop of a few cases during this session.
Yeah, so I have a few concerns, in fact, Dan, about her case. So she's a 68-year-old with A1C of 6.6% on 3 agents, including an SU. So my first concern is hypoglycemic events in someone who's older. Now, if we look at DECLARE, as you may know, had 2 co-primary endpoints. One of them was MACE, which I show you here. MACE in DECLARE was neutral. There was 7% reduction in events with DAPA compared to placebo. The p-value was not significant. And in VERTIS trial, MACE was also neutral.
So here I'm going to share the data now for the same trials that Serge nicely took us through for EMPA-REG outcomes and CANVAS and DECLARE TIMI 58, but now looking at a different outcome, at CV death and hospitalization for heart failure. The reductions in CV death and hospitalization for heart failure. And if you look at the magnitude of these, you can see they range from 20 to 30% reduction. So really substantial reductions in that risk. It's a great question. I would say as a clinical trialist, we typically use BNP to make sure as much as we can that we're getting the real McCoy.
And if we come back to the slide about how SGLT2 works, the SGLT2 inhibitors, they primarily work at the proximal tubule and primarily only at the S1 and S2 segment of the proximal tubule. Now, the field really changed quite a bit about 3 or 4 years ago with the report of the empagliflozin and the canagliflozin studies. So here we see the CREDENCE study, which looked primarily at patients with kidney disease and found that there was a marked benefit in reducing composite endpoint of development of end-stage renal disease, doubling of serum creatinine, or renal death, meaning patients died before they start dialysis, or cardiovascular death.
The CMS came to us at ACE when I was a past president to say, go tell us all the things that matter beyond A1C. Because we really are seeing that the reliance on A1C is slowly coming, if not to an end, to less of a dominance. And we generated the best list we could, but I think the evidence you discussed today, although I could not agree more, glucose is still an enemy and it's on the list of things to control. But isn't it interesting that these benefits you've talked about in the last hour or so are A1C independent?